Hi, I'm Dr. Pam Khosla. I'm the Chief of Division of Hematology Oncology at Sinai Chicago, Associate Professor Rosalind Franklin, University of Medical Sciences. This is the training module topic, Caring for Patients with Advanced Cancer, Part 1. Our learning objectives today are explain the process of advanced care planning, differentiate types of palliative care, assess reasons for referral to palliative care. Caring for patients with advanced cancer, let's start with advanced care planning. There has been a paradigm shift in advanced care planning. Paradigm shifts have happened from a legal process to a communication process. Discussion should be tailored to patient readiness and stage of health. Content and specifics should be targeted based on the patient's clinical condition. Advanced care planning is a process over time, not a form. Here is the model for stages of change for healthcare behaviors. We start with pre-contemplation on the top. This leads to contemplation of the whole idea of presenting advanced care planning, and then preparation, and then action, and then maintenance. Advanced care planning based on model of behavior changes, breaking down these different steps, taking them one by one. Contemplation or awareness means determine the patient's familiarity with advanced care planning, make the patient aware of the need for this plan. Preparation means educate and engage the patient, reflect on the patient's situation, explore patient priorities and values. Taking action generally means discuss with a proxy. That could be a family or friends. The provider and the patient talk, plan, and document. A proxy present for discussions, plan for next discussion, and maintenance, which is review and revise with changes in condition. We will now review elements of conversation for advanced care planning. Identify an appropriate healthcare proxy. Elicit the patient's understanding of their illness and assess prognostic awareness. Explore prior experiences with serious illness. Explore understanding of treatment options and impact. Explore what is most important to the patient in the context of their values. Identify priorities and trade-offs. If we look at this advanced care planning process over time, it seems to start from initial steps where we select a healthcare proxy, think about their wishes, if faced with trauma or neurological injury, and this applies to all patients with early stage cancer. And the document on power of attorney form, preparation, and execution can start right there. The next step to consider would be goals of care, which change if interventions resulted in bad outcomes or severe complications. This applies to more advanced cancer at risk for functional decline. And the final steps are end-of-life planning, establish a specific plan of care, using polls to guide emergency medical orders based on goals. Advanced cancer applies to the same final step, limited treatment options, poor function, document on a polls form. So what's the health status in early stage cancer? And what is the role of advanced care planning at that point? As we assist in identifying a healthcare proxy, things that can help in this discussion are, if you were too sick to speak with me, is there anyone you would trust to make medical decisions for you? Have you talked with this person about what is important to you? Explore the patient's goals and values for medical care. Wishes about care if the patient were to experience an unanticipated event such as traumatic injury or complications, and if unlikely to recover. Explore specific or personal beliefs that may influence decision making. Continuing with early stage cancer, the action items at this point in the advanced care planning process are: you may complete a healthcare power of attorney for healthcare form. You can discuss with the identified healthcare proxy to determine their willingness to serve as an agent. The patient reviews their values with their healthcare proxy. As the disease progresses and there's a resulting functional decline, We need to explore the patient's understanding of their illness and potential complications. Leading questions could be, what is your understanding of your illness? How has your illness affected your life? What have you been told about the possible complications that can occur from your illness or the treatment? How much information would you like to know about what may happen during the course of your illness? As the risk for functional decline continue, you can also ask the patient about exploring their prior experiences. Have you had experiences with yourself or family or friends who became seriously ill and decisions about life-sustaining treatment had to be made? What did you learn from those experiences? When you were in the hospital recently, what was that experience like for you? Continuing with this concept, you need to cultivate prognostic awareness in the patient. What is your sense of what the future holds? What is your sense of what is happening now? What has your team told you about your illness and what to expect? Would you like to know more? Have you ever thought about what it might be like if you get sicker? Explore the patient's goals, fears, and worries. If your health situation worsens, what are your most important goals or desires? What are your biggest fears and worries about the future in terms of your health? Identify the patient's priorities for function and possible trade-offs. What abilities are so critical to your life that you can't imagine living without them? What side effects are you willing to experience as you undergo treatment? If you became sicker, how much are you willing to go through for the possibility of gaining more time? How much does your family know about your priorities and wishes? Offer to meet with the family and the healthcare proxy or either one of them. So, recapping the action items again, identify a healthcare proxy and complete the power of attorney form for healthcare if not previously done. Remember to respect the patient's information preferences. That is, the way the patient prefers to hear and receive information from a medical team member. Schedule a meeting with the healthcare proxy or family based on the patient's preference for information sharing. As the cancer advanced to limited treatment options and functional decline, we need to re-explore the patient's understanding of their illness and complications, explore their prior experiences, advance the patient's prognostic awareness. Some of the questions may be, how much do you want to know about the likely course of this illness? Assess patient readiness. Would it be more important for you to have information about how much time you might expect to live? What kind of information do you want about the future? For example, average time to live. Would you like to know best or worst case scenario? And how much functional decline are you going to expect? Provide support and guide communication if making recommendations for comfort care. Tell me, what are you most worried about? What are you hoping for? What is most important to you about how you spend your time? Who is a support in your life? How do you define quality of life? Offer hospice as an option of support for patients when their goals are for comfort or when their limited treatment options or poor functional capacity. Action items again. Identify healthcare proxy, complete a power of attorney if not previously done, establish a plan of care and a framework at this point for addressing patient wishes about life-sustaining treatment decisions. This may include CPR, intubation, selected interventions, comfort care, artificial nutrition, all outlined on the POLST form, which can now be completed. POLST stands for Physician Orders for Life-Sustaining Treatment based on individual patient wishes. Prepare the patient, family, and staff for possible course of functional decline. NCCN guidelines for palliative care outline this process very well and divide it into estimated life expectancy, years to months, months to weeks, and emphasizing patient education, addressing transitions of care, referral to hospice care agencies, psychosocial assessment about legacy work, grief counseling, spiritual assessment, and spiritual support as needed, funeral and memorial service planning, Respect goals and needs of the patient or family or caregiver regarding the dying process. Inform other involved healthcare professionals of the patient's death. And with the dying patient, acceptable outcomes are reduction of patient and family caregiver distress, acceptable sense of control, decreased caregiver burden, optimized quality of life. If hospice is unacceptable, reevaluate palliative care interventions and intensify as possible with ongoing reassessment. When the life expectancy is years to months, assess decision-making capacity, like we discussed, identified surrogate decision maker if necessary, ask the patient if they've completed an advanced care planning document, encourage them to do so, refer to a social worker, explore hopes, worries, fears, initiate discussion of personal values, make recommendations about future care, document patient values, including MOLST or POLST. MOLST is medical orders for life-sustaining treatment, initiate discussion of palliative care options, including hospice. Acceptable outcomes are outlined above as before if it reduces distress. If hospice is unacceptable, explore reluctance, engage in advanced care planning, explore fears and worries again, refer to specialized palliative care service, consider referral to a mental health clinician to evaluate mental health issues, and a spiritual care counselor may be helpful. Role of palliative care and programs and consult services includes earlier symptom management, supportive care expertise that they provide, and possible impact on life expectancy. Definition of palliative care includes palliative care seeks to prevent, relieve, reduce, or soothe the symptoms of disease or disorder without affecting a cure. Palliative care, in this broad sense, is not restricted to those who are dying or those enrolled in hospice programs. It attends closely to the emotional, spiritual, and practical needs and goals of patients and those close to them. This is how the Institute of Medicine defined palliative care in 1998. Prior to that, in 1990, WHO had defined it somewhat similarly as the active total care of patients whose disease is not responsive to curative treatment. Control of pain, of other symptoms, and of psychological, social, and spiritual problems is paramount. The goal of palliative care is achievement of the best quality of life for patients and their families. Many aspects of palliative care are also applicable earlier in the course of the illness in conjunction with anti-cancer treatment. The continuum of care may start off with curative treatment goal, transitioning to survivorship, and then palliative care and hospice if the disease progresses or recurs, and bereavement in the end. NCCN for 2022 has revised the definition of palliative care to be more broad and inclusive. It is an approach to patient, family, or caregiver-centered healthcare that focuses on optimal management of distressing symptoms while incorporating psychosocial and spiritual care according to patient, family, and caregiver needs, values, beliefs, and cultures. Goal is to anticipate, prevent, and reduce suffering, promote adaptive coping, and support the best possible quality of life for patients, families, caregivers, regardless of the stage of disease or the need for other therapies. It can begin at diagnosis, be delivered concurrently with disease-directed life-prolonging therapies, and facilitate patient autonomy, access to information, and choice. Palliative care became the main focus of care when disease-directed, life-prolonging therapies are no longer effective, appropriate, or desired. Palliative care should be provided by the primary oncology team and augmented as needed by collaboration with an interprofessional team of palliative care experts. Palliative care focuses on, from this perspective, patient, family, caregiver-centered care, management of pain and other distressing symptoms, psychosocial and spiritual care, based on patient, family, caregiver needs, values, and culture. The goal of palliative care is to anticipate, prevent, and reduce suffering. support the best possible quality of life for patients and their family and caregivers. It begins at diagnosis, is delivered concurrently with disease-directed therapies, facilitates patient autonomy, and it becomes the main focus of care. It's initiated by the primary team, but augmented by collaboration with interdisciplinary palliative care experts who can be board certified palliative medicine physicians or advanced practice nurses and physician assistants, counselors, social workers, or psychologists, chaplains, pharmacists. The primary oncology team provides palliative care as a standard skill and competency expected of all physicians and healthcare professionals. Guidance with complex decision-making and goals of care discussion, pain assessment and management, side effect and symptom management, screening for distress and palliative needs at initial visit and at appropriate intervals, and connecting patients with indicated services. Comparison of primary palliative care provided by the primary oncology team to palliative specialist care. As a patient has items on the right, consultation with palliative care specialist is indicated. For example, primary oncology team can handle patient's pain if it's well controlled. Palliative care team referral is needed if pain is interfering with patient's life and or pain intensity is not controlled. Controlled symptoms and side effects can be managed by the primary oncology team. Uncontrolled symptoms and side effects need palliative care help. Mild to moderate distress can usually be managed by the primary oncology team. Moderate to severe distress, palliative care team would help. Patient family goals, decision-making, care planning are all aligned. The primary oncology team can continue to provide palliative care. You need specialists if there's concerns about decision-making and or course of disease, or at any point that patient or family requests palliative care. Palliative care programs generally provide co-management with the oncologist to assist with management of advanced symptoms, discuss goals of care and complicated advanced care planning conversations, provide services to patients who will recover from their cancer, as well as patients that will not, can help align patients' decision-making with their goals at important junctures in care. During the creation of a goals of care plan, in the event of disease progression, or when determining whether or not hospice is appropriate, when transferring to home-based palliative care. What are the types of palliative care programs? There's palliative care inpatient programs, palliative care outpatient clinics, and palliative care outpatient home-based programs. Inpatient programs usually involve a team with a physician and an advanced practice nurse, sometimes including a psychosocial team member. Inpatient palliative care programs can be certified by the Joint Commission. Outpatient clinics include MD or APN, and they may have outpatient staff appointments. Home-based programs are moving towards a nurse practitioner case management model, may or may not have a physician. Unlike hospice visits are usually billed similar to an outpatient visit, typically one 30-minute home visit per month by APN focused on symptoms and review of care. Care can usually be initiated in 1 to 3 weeks from referral. Comparing home-based palliative care programs to home-based hospice programs, the differences are palliative care programs may or may not have 24/7 call coverage, may have appointments with an advanced nurse practitioner 1 to 2 times per month, may have physician oversight and ability for physician counsel visits. While home-based hospice does provide 24/7 emergency call, an RN case management usually visits 1 to 2 times per week. MD oversight and ability of MD and or APN to see patients at home. Home-based palliative care program does not cover medications, medical equipment, or oxygen. Patient is still being cared for by primary physician and care team. For hospice, though, Medicare pays all charges related to hospice. Most private insurers also have benefits. In most states, Medicaid pays all charges related to hospice. Primary physician may remain involved in care or care can be delegated to hospice physician. Palliative programs provide interdisciplinary team support, but not always, while hospice usually includes interdisciplinary team support with physician, nurse, social worker, chaplain, and home health aide. Ancillary services like volunteer services, alternative therapies, and bereavement support are usually part of hospice programs. So, what are the reasons for referral to palliative care? If you need someone to support or lead challenging advanced planning or goals of care discussion, someone has progressive disease where uncontrolled symptoms interfere with quality of life or performance status, patient has a cancer diagnosis and has failure to thrive or frailty, patient or family requests a palliative care consult, patient has life-limiting cancer and poor functional status, for example, ECOG of 3, and the patient or healthcare agent has declined a hospice referral. Palliative care can help align those goals. Patient has chemotherapy refractory advanced cancer with a good functional status and is not being yet referred for hospice. Palliative care would be very appropriate. Has any stage cancer diagnosis, but quality of life and or survival is limited by debility, has frequent hospitalizations, and or other concurrent chronic medical issues such that prognosis is less than 1 year. Referral for inpatient non-ICU palliative care includes all of the points we just discussed. Plus, patient has life-limiting oncologic illness and prolonged hospital stay greater than 7 days without evidence of clinical improvement. Patient has stage 4 malignancy or refractory hematologic malignancy in addition to poor functional status, or patient is a current or past enrollee of hospice program. What are the conditions that need palliation often? Palliative care, common conditions that need drug interventions include dyspnea, usually controlled with opioids, alternatives to morphine or opioids for patients with renal compromise. For acute progressive dyspnea or for patients who are opioid tolerant, more aggressive titration may be required. For anxiety, lorazepam 0.25 to 1 milligram PO Q4 hours for benzodiazepine naive patients. Dyspnea, if it lasts weeks to days in a dying patient, in general, opioids are the go-to drugs. For patients who are opioid tolerant, more aggressive titration may be required. And the dose of lorazepam, again 0.25 to 1 milligram if they're benzodiazepine naive. And if they have fluid overload, dyspnea can be relieved by furosemide. If they have excess secretions, glycopyrrolate, IV or subcutaneous Q4 hours PRN, or easier to use a scopolamine patch, 1.5 milligram, 1 to 3 patches Q72 hours, or atropine ophthalmic solution, 1 to 2 drops Q4 hours PRN, excess tearing, or sublingual hyoscyamin is a good choice as well. If the life expectancy in a patient with anorexia or cachexia is years to months, identify and correct depression-related anorexia with mirtazapine, a good drug. Doses 7.5 to 30 milligrams POQHS. For gastroparesis and early satiety, think about metoclopramide, 5 to 10 milligrams PO 4 times a day, 30 minutes before meals and at bedtime. Low or no appetite, olanzapine seems to help as well, 5 milligrams per day PO. For patients with anorexia and cachexia with short life expectancy, in a dying patient, for example, olanzapine can again be tried 5 milligrams per day, or dexamethasone 3 to 4 milligrams per day PO, or consider a cannabinoid. For nausea and vomiting control, we have a lot of drugs, and there are separate guidelines for anti-emesis for chemotherapy and radiation-induced nausea vomiting. But in the patient that has limited life expectancy, keep in mind gastroparesis can be controlled with metoclopramide, CNS involvement, best response to dexamethasone 4 to 8 milligrams PO or BID or TID. Gastric outlet obstruction can also get some relief with proton pump inhibitors, metoclopramide, and dexamethasone. Gastritis and GERD have to be kept in mind and may need proton pump inhibitors, medication-induced gastropathy, again metoclopramide, then non-specific nausea vomiting with 5-HT3 receptor antagonists or dopamine receptor antagonists. Haloperidol can be a good rescue, 0.5 milligrams PO TID or metoclopramide, 5 to 10 milligrams PO QID 30 minutes before meals and at bedtime. Or campazine, maximum daily dose 40 milligrams daily, or olanzapine, ondansetron being a commonly used drug. If there's anxiety related to the nausea vomiting, lorazepam seems to help, and a vertiginous component can be controlled with an anticholinergic and or antihistamine. If life expectancy is limited, also consider appropriate route of administration. Oral, sublingual, or rectal, all different routes can be explored and titrate to maximum benefit. If nausea vomiting persists, provide PRN, scheduled or continuous parenteral infusion. Consider subcutaneous administration as an alternative. Titrate to maximum benefit. Consider additional agents like dexamethasone, ondansetron, scopolamine, meclizine. For constipation management, for patients with limited lifespan or for patients with longer lifespan, prophylaxis can be by titrating the senna and polyethylene glycol. Recommended starting with polyethylene glycol if the patient is not on opioids and can tolerate the volume of liquid. Generally, add bisacodyl, titrate 10 to 15 milligrams PO daily to TID with a goal of one non-forced bowel movement every 1 to 2 days. Persistent constipation, you can try bisacodyl suppository, 1 rectally daily BID, polyethylene glycol capsule with 8 ounces of water BID, lactulose 30 cc's BID or QID or 60 cc's daily, or sorbitol 30 cc's Q2 hours, and magnesium hydroxide or magnesium citrate. Opioid-induced constipation, you can consider methyl naltrexone or linaclotide is now available as well. Naloxegel, PO, for post-op. Ileus and mechanical bowel obstruction, though do not use naloxegel. For diarrhea, all different stages of life, it's important to grade it. Grade 1 diarrhea, loperamide 4 milligram PO once, and then 2 milligram after each loose stool, up to 16 milligrams per day. Consider addition of bulk forming agents with caution in patients on opioids. Not on opioids, consider diphenoxylate atropine, 1 to 2 tablets, POQ 6 hours, maximum 8 tablets per day. For grade 2, initiate or continue the loperamide, 2 milligram after each loose stool, up to 16 milligrams per day, 4 milligram with the first episode of diarrhea. Consider hyoscyamin 0.125 PO or sublingual Q4 PRN. Atropine may be helpful as well. Keep C. diff-induced diarrhea on your differential and consider metronidazole 500 PO, 500 milligrams PO IV. Less preferred, can be used 10 to 14 days course usually. Vancomycin has to be given PO 125 to 500 milligrams QID for 10 to 14 days again, if that's chosen. For non-C. difficile infection, treat appropriately based on culture findings. For immunotherapy-related diarrhea, dexamethasone 4 to 8 milligrams per day, and in severe cases, infliximab 5 milligram per kg, Q2 to 6 weeks. Patients requiring hospitalization for grade 4 diarrhea, continue the previous measures. And if patient is not on opioids, diphenoxylate atropine, Lomotil, 1 to 2 tablets Q6. Consider hyoscyamin, atropine, also consider octreotide, 100 to 200 micrograms per day subcutaneous Q8 or by continuous infusion. In a dying patient, diarrhea can be reevaluated by ongoing antidiarrheal anticholinergic agents increased dose of around-the-clock opioid. Consider atropine, octreotide, or glycopyrrolate. Glycopyrrolate can be given 0.2 to 0.4 milligrams IV Q4 hours. For malignant bowel obstruction, which can be a challenging condition, reduce the opioid dose or rotate opioids. Consider metoclopramide, dexamethasone. 3 to 5 day trial is usually enough. Scopolamine patch, hyoscyamin, glycopyrrolate may be tried. Octreotide infusion or subcutaneous again. If prognosis is more than 8 weeks, consider long-acting release of octreotide, the LAR or the depot preparation. How about sleep-wake disturbances, insomnia, daytime sedation, or restless leg syndrome? As outlined, multiple drugs are of useful consideration: trazodone, olanzapine, zolpidem, mirtazapine, chlorpromazine, quetiapine, and for phases shift disorder, consider Remeltion, 8 milligram PO 30 minutes before bedtime, or melatonin. For daytime sedation, consider caffeine, 100 to 200 milligrams PO Q6, last dose at 4 p.m., methylphenidate, PO/BID, dextroamphetamine, modafinil can all be valuable for countering sedation. For restless leg syndrome, ropinirole is an important drug and may also consider pregabalin, carbidopa, levodopa, or low-dose methadone with dopamine agonist. Delirium or sedation can again be managed. For delirium, Haldol or risperidone, olanzapine are important drugs, sometimes Seroquel or quetiapine. For severe delirium or agitation, haloperidol and alternatives like olanzapine or chlorpromazine. For high-dose neuroleptic refractory, consider adding lorazepam. For a dying patient, upward titration of haloperidol, risperidone, or olanzapine. In high-dose neuroleptic refractory patient, upward titration of the lorazepam. Consider alternate routes like rectal or IV haloperidol. Consider chlorpromazine, 25 to 100 milligrams PO or per rectum at bedtime. For an imminently dying patient where palliative sedation is desirable, midazolam or lorazepam, continuous infusion is valuable. Phenobarbital, propofol, continuous infusions may be alternates as well. In summary, the process of advanced care planning was explained. Different types of palliative care were compared, and reasons for referral to palliative care were assessed. I hope that was a good overview of the topic. Thank you.